Welcome back, everyone, and we're going to keep this conversation about oral ties going. Alrighty, so these are the different degrees. They're 4 degree based on Dr. Cutlow. He was the one that was diagnosing and treating individuals with oral ties back, I want to say in the 70s and 80s. He was the only one at the time that recognized that there were oral ties, and then throughout the years and time, more data, more science have been revealed, letting us know what is the anatomy and the functionality of the tongue and what's going on underneath it and beyond. So he categorized 4 different types of tongue ties. Number one is the classic. It's right at the tip of the lip of the tongue. This is the one that it's noticeable even to the naked eye. A blind person can see this per se. Then number two, this is, oh, sorry, let me go back to number one. So number one, there's no range of motion, right? When the tongue is tied at the very tip of the tongue, the only function that the tongue might have is in the center. This is where the tongue, I'm sorry, I was blocking it myself. This is where the tongue just moves barely only on this in the center, right? That's all. That's all they're getting. So parents might tell you, I feel like somebody's like the baby's punching me with its tongue. And that's because the tongue can't come out of the mouth, right? And grab the nipple and kind of come back and forth. It's tight there. Think of it as like a bungee cord. It's just holding this tongue completely flat down. These are also individuals that later in life, they might talk with a lisp because there's very minimal range of motion in that tongue. So a lot of letters that involve the tip of the tongue touching the palate and pronunciating things like, for example, the R and S are impacted. So then we have number two. So number two, the membrane is a little further down, but there is some elevation. But if you notice on the image, the tongue lightly kind of folds, right? There's no full fold to the tongue because that membrane is holding it from a little further down. And classic U, right? You will see that classic U. Then number three, it's a little further down. We call that posterior, right? The first, number one and number two are called anterior ties because they're closer to the tip of the tongue. Then we have posterior tie for 3 and 4. These are membranes that are a little further down and sometimes even a little further in the tongue muscle. And that is also a bungee cord. So if you can see in the image, there is some elevation, but you can tell that that tongue is not going to touch the palate. So this is where also a parent might reports that feeding maybe is not as extremely painful in comparison to number one, number two, but with number three and number four, the parents experience some soreness, but baby can only feed 10-15 minutes and then come back 30 minutes later for another 15 minutes. And that kind of pattern continues because the baby gets really tired. Again, with the analogy of the bungee cord, when that membrane is holding this muscle down and the baby is trying to extend the tongue, curve or fold the tongue to grab onto the nipple and then bring it back and forth, or the breast tissue or the areola, and bring it back and forth, that bungee cord is constantly pulling this tongue down, and that's very tiring. I like to pair it like if a person was to eat croutons or chicharrones for us that are Latinos. It's really hard to chew, and that really tires out our jaw. So babies that have a tongue tie, in whichever degree, it's a muscle that is being forced down, and they're trying to make another motion, and then it's just exhausting. So this is where parent cannot fully drain the breast. Babies are gaining weight very slowly because they're surviving on the letdown. Once you have that natural response and the milk just releases, they're only thriving on that because anything else that involves having to extend their tongue and bring that nipple and do that full range of motion, uh, it's not there. So they're having to use or compensate, better yet, having to compensate using other motions such as kind of sucking on a straw. Some babies might use their lips to eat because that tongue is just not doing its job. So other muscles because we as human beings, we adapt and we find other ways to do things, right? So in the form of feeding, if the tongue is not doing its job as it was designed to, then other muscles will take in, or other actions will take in order to get a feeding. So lastly, then number four, this is where I was explaining before that sometimes diagnosing oral ties can be a little tricky, because to an untrained eye, number four is like, oh, well, I don't see that membrane, right? Take a look at yourself. That line, as you see in number two and number three, on number four, you if you look really closely, you can't really see where's the membrane. And it's like, well, I don't think it's a tie there. There is elevation. Parents might experience some mild symptoms, still kind of hurtful, and still battling some of other issues like draining the breast, or baby's cluster feeding, or sometimes baby will have a ton of hiccups, or sometimes baby will get a lot of gas, because if they can't seal that nipple or that areola when they're feeding, air is going to come in through the sides and it's going to look like, and that's going to cause some stomach discomforts. So at plain view, you might think, well, I don't know, I don't think there's an oral tie. And unfortunately, many pediatricians that are not trained in identifying oral ties, maybe they just didn't extend their education when it comes to oral functions. They might look at it and say, oh, it's fine, just work with a lactation console, just work on the latch, or just pump, or just bottle feed. So many quick solutions that are not realistic to some parents that do want to breastfeed. So again, an untrained eye, or a person that is just not familiar with what they're looking at, might say, "Oh, there isn't a tie," and it's just a different variation, it's a different degree, and this is why we refer to those that are skilled, those that are trained, those that are doing the work of releasing ties. And then I'll talk a little bit about, in two more sections, I'll talk about the different types of release. So, besides the variation or the degrees of the oral ties, is different ties. Remember when we were talking about the hierarchy, we talked about that there's sometimes some cheek ties, which on rare occasions they might run alone. They might just be alone. They might just be ties in the cheek, but not on the lip and not on the tongue, and that could be causing a restrictive motion in the mouth, and the parent might not have a pleasurable experience when they're breastfeeding. So with tongue tie and lip tie, sometimes they run in pairs, and this is why I put this two images rather closely together, because sometimes some providers might say there isn't a tongue tie, but it's a mild case of lip tie, but lip ties is okay. Baby will just learn how to feed, and that it's incorrect. This will never go away unless it's properly treated by a professional. So the lip tie, what it does is that it inhibits the lip from flanging out. This is typically when you see a baby when they're nursing, their lip curls in, and the parent will try to flange the lip out, and then they will lose the latch, and then they will latch again, and the baby again inverts the lip, and the parent again will flange the lip out and lose the latch. The baby's lip tie is causing lack of bungee cord, again, the lip, and it's not allowing it to flange out. So when it curls in, it's actually an adaptation in the feeding that the baby's trying to compensate from the lack of flanging out. The baby now tries to use the whole entire lip or mouth to try to hold on to this nipple for dear life. And when the lips curls in, it's more of a crutch that the baby's using in order to make that seal and try to do the full range of motion of bringing the nipple and doing the feeding. So sometimes when parents do flange out and the baby can stay latch, awesome. There might be a good flexibility, still might be some tension, but some good flexibility. But if the parents continue to notice that, or notice that they continue to flange the lip and the baby loses his grip, then we let that lip curl in, because that's the crutch that the baby's using for now in order to get its meal. Um, and again, a lot of oral exercises can be practiced by a speech therapist, physical therapist, occupational therapist, osteopathic manipulative medicine, OMM, and also lactation consultants, where we do exercises to stretch out or give a little bit more flexibility of that membrane of the lip and of the tongue. So when it comes to frenotomy, or oral releases, there's two ways on how that is done. So one is by scissors, and as we see on your left hand side, the scissor, and it's like this tool which just helps get into where the frenulum, the frenulum, where the frenulum is. It's like a little space there, and they elevate the tongue, and then with a pair of scissors, they go ahead and cut that. Typically, they do that when babies have, or an individual, because you can also have this procedure done as an adult. It's better with scissors. Not better, I'll take that back. It's more seen with scissors, a procedure done with scissors, when the tie is very visible. Let me go back so you can see. When the tie looks more like number one and number two. So when it's number one, there's no tool that can fit in there because the tie is really at the tip of the nipple. So someone from behind will come and lift the tongue up as much as they can, and then the other provider will come in and then we'll do a snip. So if you think of it as webbed fingers, if my fingers would have been webbed, right, like a bat, and I come and I snip just the very tip, I can get a better range of motion of my fingers, but I didn't get the full webbing. I didn't cut the full webbing. That's because it's dangerous to further extend those scissors inside the mouth, because then we can cut into something that we shouldn't be cutting into. So for number one, number two, scissors is usually what some providers will do if that's what they were used to doing. They got practice with doing it with. Laser is more costly for them, the equipment, the practice, the training. So not everybody, or not a big range of individuals do it with lasers, but those that are skilled now can go into number one, number two, number three, and number four degree, because now they use the tool to elevate and see how far in depth. And then they go little by little with the laser, eliminating that membrane and causing an opening, allowing then for the skin to form or to heal together, and allowing for that range of motion. So if you see on the right, on your right side, you will see how the laser eliminated that frenulum that the person had, or the baby had, because you look at the small little teeth the baby had right between the teeth, and for the adult as well. So they also do this with the tongue. If you see under the upward from the word laser, the provider comes in and start eliminating that membrane. Now, there's not a lot of nerves in this section, so healing or the process afterward doesn't involve much. The exercise have to be done to avoid the diamond to kind of unite in a scrunchy way, but bleeding is very minimal, especially with laser. The laser is burning off that membrane and also sealing, so bleeding is none or small. With scissors, bleeding could be just a tad to none as well, depending on how the process was done. And in both, the parent can latch right away, and oftentimes they quickly report a significant change. Um, this is just the beginning, right? When a lot of people say, my child is tongue tied, I'm getting the process done, and that's great. But this was a muscle that was restricted in utero. So in development, some people say it's due to lack of folic acid absorption. Some people say it runs more in the family. Whichever the case may be, the point is that this is just the first step. The release, the pre and post exercises within the release is just a first step, because now we have a tongue that has a new range of motion. This tongue is completely free, and it is a muscle. So just like a person that goes to the gym to exercise their bicep, you don't just do a couple and that's it. No, you have to now build a range of motion for this tongue to understand its new natural movements. So it can start here, but it can quickly move over to working with, again, a speech therapist, a occupational therapist, a physical therapist. And this is because the tongue is a muscle that runs further deep in, and it involves the mechanics of the face muscles and also involves the body. So if you have a child that, if you have a parent that has a child that is tongue tied, and they got a procedure done and they say, hey, it still hurts, it's still bothering. That's because that was the first step. The next step is to see which other provider can be welcomed in into this new journey and provide the care that would allow this tongue to now build muscle, build resiliency, build a range of movement. So yeah. Alrighty. So for this last section, I want to talk. I know one of you guys asked about, I guess, C-section and medical interventions, and how does this impact breastfeeding, especially with breast reduction, augmentation, and breastfeeding and medication, which I'll quickly touch on the last one, breastfeeding and medication. So, um, again, with the scope of practice. So when a person is taking the medication, we looked at the database from infant risk, and we also have books as lactation consultants. I know I have a couple books where I can look up the original medication and it can tell me which level, right? Is this an L1, L2, L3, or 4? The higher the number, the more potent the medication, the more longer it lasts in the blood system. And breast milk and blood are traveling together. So anything that lives longer in the bloodstream, baby have a higher chance of also consuming the medication. So we usually take the name of the medication, we search it up, and we provide the parent with the information in their hands. Even me as a lactation consultant, I cannot tell a parent, oh, don't take it, or yes, take it, because now I'm putting myself at risk for something happening to this family and then it coming and biting me in the end. So we always want to provide the parents with the information and allow them to have a conversation with their medical provider, which chances are will tell them the same thing. Well, here's the information, read it through. I'm going to tell you the risk of what can happen if you nurse with this medication. And I can tell you the risk of what may happen to you as an individual if you don't take the medication, especially for those that have high depressive symptoms. Sometimes they need to be in medication. So it's a Zoloft. Zoloft is not a happy medication to do when you're breastfeeding because um, it it there's a higher percentage of the baby also taking some kind of medication through the breast milk, but I much rather have them have a conversation with the psychiatrist or the psychologist and talk about an alternative or talk about other alternatives such as maybe we'll pump and use this milk for a milk bath until the doctor maybe can switch the prescription, or I can stop it for some times if it's safe. Again, all this is going to come through a conversation with their medical provider. So I kind of touched on the last one and then on the C-section. Now we get to C-section. So anything from C-section to taking Pitocin, taking epidural, and I include that as medical interventions because even putting in IV fluid high in potassium is a medical intervention. Long labors I usually pair them in the word medical interventions. These two bullet points can create a little bit of a bump in the road when it comes to infant feeding. And that is because now the parent has medication that has now transferred to the child in very small doses, but we have a child that is a little sleepy, a little less cooperative. We have our body swelled up from a major surgery as a C-section. Hormonal responses are not the same because when you deliver vaginally, there's just certain hormones that have a job. I call them the army. They all have a job. So if they're robbed out of their job, then they're kind of out of whack. So when the babies are born, kind of, I always call it an exit, kind of like whoop, a quick exit, then these hormones are left confused per se about what's happening to the body. So it takes sometimes a little longer. That's not to say that a person with C-section cannot breastfeed, but sometimes it just takes an extra day or two, even sometimes 3, depending, for the body to kind of respond and kind of get with the motions. If we have a parent with Pitocin and oxytocin, with Pitocin or epidural, the baby is a little sleepy, the baby is a little confused, the baby natural reflexes are hindered because of the substance. So it takes a little longer for the child to kind of snap out of it and try to get things going. excess of IV fluids. If a person had a labor longer than 4 hours, now we're talking about excess fluids that has slipped into the chest, into the breast, and now has kind of inflated that poor breast where the nipple and the areola kind of become one. And the skin is very tight, very fluffy. Think of like filling up a balloon with either a lot of water or a lot of air. You don't have a really stretchy substance. You have a really tight skin. So the baby tries to latch into a nipple that has been flattened by the swelling, or you have a nipple that, okay, might have protruded, but the elasticity is not there because there's so much tension. So then it caused kind of like a series of cascades of situations where the parent says, well, he's not latching. And then you have a nurse that wants to do a checklist and say, did the baby latch? Just so they can check it off and kind of be done with their work and switch you over to recovery. And it could really have a parent feeling as they're not successful, or that something's going on with the baby and they just can't do this. And I was thinking about adding an extra section about pumping because it's just going to pair well. Sorry, it's going to pair well with protecting milk supply and some of the things that you can really recommend that can really make a huge impact. Which, with that, would be if the baby, right? Mom had a C-section, mom had an epidural, she had pitocin. Everything is kind of not working as they might have expected. Baby's having difficulties latching. Then we jump to pumping, but understanding that the first few days of milk, it's mostly, I always call it like a little honey. It's more of a honey substance that doesn't do well with pumping because of its thickness and also our hormonal response, right? It needs kind of all these um, hormones to participate. And if we still have kind of a little bit of the medication inside of which will take a couple hours for us to kind of fully kind of get ourselves together, then the response of that ejection reflex, remember the oxytocin, sometimes takes a little longer. You also have a parent where the nurse is constantly coming in and checking on their fundus and checking on their blood pressure. There's so much going on. Doesn't really allow the parent to be in that zone where oxytocin can be released and then milk can be then ejected. So under all that stress and under all that uncertainty, then we ask the parent to pump and to pump honey. And this is where I wanted to get you guys through and add the section. And then we're asking them to pump with the flange size provided by the hospital, which is typically either 21, 24, or 28, which are extremely big for about 99% of the individuals in this world. Very small percent of women are those type of sizes when it comes to flanges. So more realistically, it's like a size 15, a size 16, a size 17. So we're giving them their a medical equipment that is not in favor of their breast size. We're giving them a medical equipment for which we have not taught them how to use. This is an external stimuli, which not every and not everybody responds well to an external stimuli, or if they have sensory issues, too much stimulation can also be off-putting and also inhibits for the lactation for the oxytocin to release. So all of these medical intervention can just cascade to a long list of situations that in the long run just leads to a parent feeling defeated, feeling that this is just not happening, to feeling like they're doing something wrong. And it's such a very vulnerable moment for birthing families to experience because we do such a great job in promoting breastfeeding, right? We hype them up about all the awesome benefits and about how they can provide this for their children and it's their superpower. And this is the only thing that you can do as a parent that nobody else can do. And those are awesome words of encouragement. Keep using them, never ever stop. But we also want to prepare them for the unknown. And I usually leave this for when we have conversations. If they have a planned C-section, then I start giving them a toolkit where now they're preparing themselves for what's to come and how to reach me in the event of if something does go wrong, but also boosting their confidence of if this happens, you're going to jump to this. If this happened, you're going to jump to pumping. You're going to jump to hand expression. Let's learn hand expression really early on so you can kind of get the mantra of how to remove your own milk. So when this occurs, they don't have to hear the language of the medical provider or the nurse. It's saying, oh, you just can't latch, or you're just not making milk, or you don't have no milk. We have to give them formula. So that's a lot of hoopla because as of 25 weeks gestation, the mother's already prepping with colostrum. So colostrum is there. Milk is there. And we'll talk a little bit more about milk and how the body kind of like works from within, but milk is already there. It just looks different because it has a different job. Colostrum is more designed to kind of soothe the intestines. Babies are not breathing in utero. They're full of red blood cells that are doing the breathing for it. Once that placenta is disconnected, the baby's lung expand. No longer do they need the excess red blood cells, so they go straight to the stomach to be digested. So here comes Mr. Wonderful, liquid gold, prize winner, colostrum, and it's ingested. It elevates baby's blood sugar. It keeps baby safe from the environment because it has all the parents' immunity, but primarily it's soothing the stomach. It's eliminating all this tar-like poop, which is dead cells. It's cleaning out for what's to come. Coincidentally, by the third day, all that black poop is gone. It's transitioning to green because now the yellow is kind of coming through. Now that stomach has grown in size. Now it can fit. By coincidence, mom milk should have been transitioning to a higher quantity. I like to call it buttermilk, which is like straight in the middle, where first it's really darky yellow and golden, and then it's like a melted butter type of color, but in higher liquidy consistency. And then after that, it transitions to mature milk, which is it goes from a little translucent to a little darker white. Sometimes people say they shine it to the light, it looks like a little hint of blue. But the point is that it increases from in quantity, but also in consistency. It goes from thick to much thinner, higher in fat, sustains the baby longer, opposed to colostrum. Babies tend to eat it every hour and a half, or sometimes a little sooner, because the baby's belly is like the tart of a cherry, and you'll see it soon. So they get little bits, but that little bit is potent. I always like to use the joke of your mother's Kool-Aid packets, that with that little 99 cents little packet used to make 2 quarts of juice. It's true that you needed to add about a pound of sugar, but those 2 little quarts of coloring um, gave you 2 quarts of juice. I always say colostrum is the same. That little bit of colostrum goes a very long way. So to end this section, because now we're going to get to the nitty gritty, it's a couple of videos I want you guys to watch. You're going to love it. Um, when we talk about medical interventions, even as something small as excess fluids, it can impact the response of the way the glands are secreting milk. But we can do things to help the parent in that moment so they don't feel defeated. First, words of encouragement. This is just a small pebble in the road. This is just a small bump in the road. Feedings typically, anyways, go up and down. Just when you thought you had a pattern, baby hits a curve, and now it looks completely different. So if formula needs to be offered, it could be offered via syringe. It could be offered via bottle. It doesn't matter. I always like syringe better because they're so tiny. We want to still try to put them back to the breast or try to feed them a little formula while at the breast. But the point is that formula here can be a bridge. This is why it was designed to be a supplementation, right? So it's formula supplement. So it could be used as a bridge to help keep baby blood sugar spiked so they can actually surface and come for feeding. It can fill the tummy and provide all those nutrients for everything to just continue to function how it needs to be while the parent is working externally in stimulating their breast by hand expression, by stimulating the breast with a breast pump, but using the correct flange size and the correct pump. The pump in the hospital, mistakenly, many people call it hospital grade. The FDA sent a memo which says no way, shape, or form is that a hospital grade. They never called it that. They don't know why people call it that. It's called a multi-user pump. The only way that it's a hospital pump is because the way it was designed is really huge, is bulky. The reason for that, it has different layers to protect the machine from bodily fluids, meaning that if you and I use it, When you use it, no milk is going to touch anything inside the pump that is then going to transfer to me when I get to use it. So this is a hospital multi-user pump, and then you have the parent use their personal pump. And that's where I like to recommend parents to take their own personal pump. And if they received it before delivery, they got a chance to practice, they were measured for the correct flange size. Now they're pumping with the correct size, with the pump that they're familiar with. And now externally, they can work on their part while the baby's being fed by supplementation. So let me give you a sneak peek of what's to come on the next section. So we're going to transition now to how does this all work? Like, this amazing human body creates this milk from where and how does the brain communicate with the uterus and the breast, and how does these glands that I talk so much about fill up with milk, and how are they squeezed out of our body. So get ready for the next section. You're gonna see a cool video that breaks it down step by step. See you guys soon.